This week, for the topic of musculoskeletal, I chose Pectus Updates and Special Considerations in Marfan Syndrome, published in Pediatric Reports, January 2017. In the picture to the left, you can see Panel A demonstrate a good representation of the impact of carnitine. A is a mild case, and B is a severe case. It's also referred to as pigeon chest. And excavatum is reflected in C and D in the bottom two panels. And you see the first one is a mild case, and the second one is a severe case of this syndrome. The prevalence of pectus is about 0.8% in the general population. However, 70% of the patients with Marfan syndrome have this condition. The histology studies done demonstrate dysfunctional collagen deposition, where they have noted immature collagen matrices in the cartilage examined in children. The pathophysiology involves the development of an abnormal rib cage. There's elongation of the costal hyaline connection between the sternum and the ribs, compression or protrusion of the breastbone with asymmetry, and possibly misalignment and sternal tilt. Ribs may be elongated, rotated, deformed, fused, and flattened in the development of this syndrome. Generally, signs and symptoms for excavatum are more serious because of the ratio between the front of the chest wall to the back of the chest wall being so severely impacted by depression. Typically, with carnitine, there are not too many symptoms, and the main problem is psychological distress, as this disorder really presents itself primarily after large growth spurts, such as in adolescence and young adulthood, with a prevalence of 4-to-1 male to female presence. Signs and symptoms that are adverse may present as exercise intolerance, chest pain, dyspnea, palpitations, depending on severity, and of course, psychological distress. The presence of pectus with Marfan syndrome, a primary inherited connective tissue disease involving a deficiency of fibrinogen 1, warrant distinctive consideration and treatment given Marfan's systemic and potentially life-threatening effects upon the respiratory and cardiac symptoms. Also, excavatum occurs sometimes together with congenital heart abnormalities, and connective tissue effects can be more severe, clearly. Reoccurrent pneumothorax, sleep apnea, and lung fibrosis are included in the concerning patients. The longer we study and learn, we're always reminded of the importance of a thorough physical and history, and this is the case for pectus. Certainly with carinatum, it might be primarily a body image and a psychosocial issue, and the importance to the patient is what needs to be fleshed out rather than the parent's impression of it. This picture shows them measuring the sternal angle, which will help you understand underneath the chest wall how much deformity is there. And in panel B, they're measuring the chest wall from side to side, side to side and from front to back. And the 2-to-1 ratio that we expect is typically an absent finding. In milder cases of pectus, diagnosis can be made through physical assessment and history taking. However, when treatment is initiated and when cases are more severe, diagnostics are conducted through CT, MRI, and 3-dimensional body scans, where they index the amount of deformity. Diagnostic measurements are looking at the AP, anterior posterior maximal chest wall distance, and the lateral chest wall distance and proximity, and of course impact to the vital organs. Balancing diagnostic measurement of deformity and prioritizing minimizing radiological exposure is a current priority, and that's why MRIs are sometimes preferred. There is early research on a path to develop a physical assessment based on pure indexing by non-radiologic methods, and it's quite exciting. This is a picture of a young man with pectus carinatum and the deformity prior to intervention and months after manipulation and continuous bracing, external bracing. And this is an example of effective medical management of this condition. This is a picture of a surgical repair of a modified Radvich procedure. It's an open repair of a severe pectus excavatum, and you can see that next to the sternum they've inserted mesh, and they're also identifying the disarticulated ribs, which it's hard to see, but they're definitely not where they should be. And there's the closure photo. For excavatum, here's a couple more procedures, a little more minimally invasive. The one on the left is the Nuss technique, and in this technique they do insert banding, and in this case they put one in, but sometimes they will put two in. And on the right they've corrected the deformity with a custom-made silicone implant. Monitoring these patients and giving them the correct support is very important. And there's always a risk of the underlying disease making these repairs reverse. One of the biggest problems with carinatum is compliance, and patients just don't stick to the continuous bracing. So there's lots for us to do, and I thank you for your time.